My team probably doesn't. You know, like that's.
All right, good afternoon, everybody. We would like to start one of the afternoon sessions here. Thank you for sticking together for one of the last sessions of the Saturday. So this one is Advances in Acute Pancreatitis. It is my honor to co-chair or co-moderate this session with Dr. Mark Lowe from Washington University School of Medicine in St. Louis. I'm Aliyah Witch from University of Iowa State Family Children's Hospital. We have wonderful speakers, and this is Advances in Acute Pancreatitis, and I will let Dr. Lowe introduce the first speaker.
Okay, good afternoon, everyone. Our first speaker is Dr. Maysam Abel-Hajjah. And this says associate professor, but she was recently promoted to full professor of pediatrics at the University of Cincinnati. She's a pediatric gastroenterology there, the medical director of the Pancreas Care Center at Cincinnati Children's, and the medical director of the Ohio-Kentucky chapter of the National Pancreas Foundation. Of course, co-director for the NPF annual meeting, chair of the Pancreas Committee for the American Pediatric Gastroenterology, Hepatology, and Nutrition Society, which doesn't yet have pancreas in there, but we're working on it. I think in all the fairness, Maysam has probably done the most investigations in pediatric acute pancreatitis of anybody in the United States over the last 5 years or so. And she will talk to us today on managing pediatric acute pancreatitis.
Thank you. Okay. Good afternoon, everybody. Thank you for the introduction. Thank you for the organizers of APA for inviting me to speak. It's a true pleasure to be here. I'll walk you through a little bit of a journey. My co-moderators are one of the best mentors I was blessed to have when I was in my training. And this is truly a journey. So I'm going to try to hit few points to show some of the important advancements in acute pancreatitis in children. One of the findings that epidemiologically through this work led by Zach Sellers and Walter Park from the Stanford group looked at the Truven database with over 140 million admissions in children and adults. And what they concluded is that the incidence of pediatric acute pancreatitis is indeed stable through the time, but also that in adults it's probably declining. And in pediatrics, it's not insignificant. It's 10 per 100,000 cases. When you face a patient with acute pancreatitis, a number of questions come to mind. Would you admit them or send them home? Would you decide which service would manage them? Historically, this is a disease that only surgeons took care of, and now more and more it's medical practitioners. Laboratory markers, what pain control measures, imaging, IV fluid, would you allow them to eat? And if so, what type of diet? And how about other tests? And when do you involve your pancreas colleagues or even surgeons or ERCP? One of the advancements that we had made and taken on is that we have built an observational cohort study of index admissions of acute pancreatitis in children in Cincinnati. The registry is in 7th year, and there are different kind of studies that came out of it. This was one of the important studies that really touches on how do you even diagnose it. So the role of lipase alone was 95% sensitive. If you check with amylase alone, it had less sensitivity. And in terms of imaging, ultrasound, which is the most commonly utilized imaging, is only about 50% sensitive. So if it's negative, we really urge the providers to consider cross-sectional imaging. In terms of diet, when we asked that question, while this is a simple and designed study, we looked at 38 mild acute pancreatitis admissions through a nutrition database where we collected data prospectively. We have shown that early nutrition is safe, feasible, and was not associated with adverse pain outcomes in acute pancreatitis. And in fact, the patients who were allowed to eat compared to the patients who were not allowed to eat, this is a provider-driven decision, had similar pain scores. And the figure that I show here showed that the higher fat intake was actually associated with lower pain scores. So and then when we looked at the length of stay and whether it was affected by the average fat intake over the hospitalization, that did not change. So it does beg the question if we even know the definition of what is a low-fat diet, because when we surveyed nutritionists, over 100 of them, pediatric nutritionists, no one knew what is a low-fat diet, but is it really needed? We built an order set and incorporated that into our electronic medical record, EPIC, and I'm just going to show snips here. And the main reason was because we have a large institution, over 800 beds, we needed to standardize management. Some of the call to action was to feed the patients on admission, clear liquid diet, and then you advance within 6 hours to regular diet for age. And in terms of IV fluids, aggressive IV fluid, 1.5 to 2 times maintenance, and we default to isotonic fluids, and we let the providers choose normal saline or LR. Flora Szabo, doing her fellowship with us, looked at this when the patient who were allowed to eat on admission or kept NPO for the first 48 hours, and the patient who got the aggressive fluid management were high IV fluid and who didn't get the low IV fluid. By these 4 different groups, factorial design, you end up with IV fluid that are low and NPO patients compared to other groups. The first group had 35% severe acute pancreatitis rate, and it decreased over those cohort, and the group that managed through the order set had the best outcomes, early PO with aggressive IV fluid management, was associated with a less severe acute pancreatitis rate at a 4%. This was not a randomized study, so you can say this is one of the main limitations, but we needed to start somewhere. What type of fluid? Dr. Peter Farrell is one of the experts in that topic, and he really took in a lot of interest in studying it. So recognizing that when we have databases like the Pediatric Health Information System from 47 major hospitals, comparing LR compared to normal saline, this is a study that had over 1,500 patients. The LR had less length of stay. He had also shown that it had lower infection rate, lower TPN rate, and a lower cost of admission. And then went on, and you heard about this, and if you visited his poster, to design a randomized control study for LR versus normal saline for acute pancreatitis management. The targeted enrollment was 80, but we ended up a few patients short. And the primary outcomes were CRP at 24 and 48 hours, and the surrogate or secondary markers for severity were length of stay and the severity itself. For the primary outcomes, LR and NS group had similar CRP levels at 24 hours and 48, so we did not see a significant difference. But the overall length of stay, while you might see it probably shifted a little bit, including to this histogram, to favor lower length of stay in the LR group, it was not statistically significant. But when we zoomed in on the rate of discharge of patients within the first 72 hours, and this is important for outcome measure because your intervention is really for the first 2 days. So to measure the outcome immediately after really made sense. It was definitely favorable in the LR group. Acute pain management of acute pancreatitis. I had the pleasure of working with a bright individual, Irina Gorbunova from Seattle Children's, and her mentor, Tonia Palermo, through the CAPER program. So a big plug to the CAPER program. And through that study, we looked at the association of opioid administration with clinical and socioeconomic factors. And we also explored the opioid administration, how it affects the length of stay and different demographic factors. And here she went on to explain the different type of medications over this decade period that are used in a children's hospital. And I would think the major findings were that multimodal analgesia, when you use more than one agent, resulted in less opioid use. So something to really consider compared to using no multimodal. And through multivariable linear regression for predicting length of stay, opiates did not increase length of stay. So if the patients are in pain, we need to make them comfortable because it's truly a painful disease. The Pancreas Committee, and I would say in collaboration with Dr. Peter Banks, Dr. Darwin Conwell, who had helped set the guidelines for adults, helped us as pediatricians set the guidelines for how do we classify severe acute pancreatitis. And I would say that was a very important effort because now we have a definition through which we can compare effectiveness through different studies. Does severe acute pancreatitis happen in children? Of course it does, and that is one of my major interests, to predict severity and hopefully improve the outcomes. These are images within the same patient. The red area is pancreatic necrosis and peri-pancreatic necrosis, the child to have even more progression of that within 10 days. And that was a child that really stayed in the hospital for a long time. Dr. Vitali and Dr. Farrell helped us design some of the models for clinical variables that you obtain on admission to predict severe acute pancreatitis progression. And this model that I show was really over years where we had a derivation cohort, then a validation cohort, and then in other institutions. And the story short is that blood urea nitrogen as a single marker was one of the most important predictors of severe acute pancreatitis. And if you add low albumin on top of it, it improved the prediction of that model. Working with Dr. Aida Habtizion and her group in Stanford from her time there, we looked at the utilization of Luminex assay to investigate novel biomarkers in severe acute pancreatitis. And I here summarize that IL-6 and MCP1, monocyte chemotactin protein 1, were significantly elevated on admission in the patients that progressed to have severe acute pancreatitis down the line. This not only explains the role in prediction and risk stratifying the patients, but could get you a glimpse into the pathophysiology and mechanisms of severe pancreatitis, and hopefully partnership with you all and the industry to design targeted therapies. The NASPGHAN committee, under the leadership also of Dr. Andrew Trout, had a joint effort with the Pediatric Radiology Society and came up with imaging guidelines. What is the role of imaging in the management of pediatric pancreatitis? It's a very big paper, but I included here the nice diagram. It's a nice cartoon that JPGN lets us have. Consider ultrasound on presentation, rule out gallstones. It's negative, move on to cross-sectional imaging. And if it's a complicated course, do not do ultrasounds, get cross-sectional imaging because you really need to define when and how to intervene. The same committee published management guidelines, and I'm going to summarize here a few of them. Confirm the diagnosis, assess the patient at time of presentation. There are models for severity prediction. They could really help you decide who should manage the patient and how should they be managed. There are roles for IV fluid hydration, allow for early feeds, and then watch for the progression of the symptoms and the lab directions as well in pain control and analgesia. But is it really a one size fits all? I don't know. And maybe because the diversity of etiology in children, as I will show you, it's probably not. The previous studies in acute pancreatitis, while they were mostly retrospective, we went on to design the prospective registry to predict severity, identify management elements that are the best associated with the outcomes, and then hopefully even predict the recurrence before it's too late. This is the registry design. They get enrolled, and then we see them at 3 months and 1 year. The 3 months and 1 year is really for exocrine and endocrine-related complications, and it's paired with genetic and biomarker studies, tool microbiome that you heard earlier this morning, and patient-reported outcomes. In terms of the etiology, Dr. Sohail Hussain from his time at Yale looked at the role of medication and other etiologies in acute pancreatitis. And then we partnered together 10 years later and replicated the results. But even more so, we really found that medications are the leading cause of known pancreatitis in children. And if you look at it on its own, it is common. With other factors, it gets up to the quarter of all cases. So because the etiologies are so diverse, I would say some of the management elements that we learned from the registry, I'm going to summarize them here. Some of it is still not published. It could present as part of IBD, treat IBD. Because if it's severe IBD, the pancreatitis is not going to resolve. Autoimmune pancreatitis, different management. You start with steroids and you max out at 60. And if you fail the first round, you got to really think, how am I going to diagnose accurately and then target the therapy? Gallstones is easy. And then hypertriglyceridemia. This is the patient that I would leave NPO until their hypertriglycerides level is improved, so below 500. Traumatic pancreatitis is a big topic, and there's trials now in the United States looking at whether you should intervene surgically or through an ERCP early on, but definitely try to bridge the leak as soon as possible. And then drug-induced acute pancreatitis. What is after the first attack? In the next maybe hopefully minute or two, I'll cover that. Once the patient is done, they're not done. Exocrine and endocrine compartments rely on the pancreas, so we believe that both could be affected even from a single attack, and I will show you data to support this, and same thing for patient-reported outcomes. When we looked at diabetes, in 52 patients, it was present in 13. The median time was about 1 year. Higher age, BMI being high, and severe pancreatitis were all risk factors. And genetic predisposition, CFTR variants did play a role in progression to diabetes. One of the newest studies, and I'm so excited about it, and it's in collaboration with these super smart people, is really studying the time and the type of diabetes after a single attack of acute pancreatitis. And we test for markers for type 1, type 3C, and type 2 through a mixed meal tolerance testing. This is still ongoing. And the quality of life, we were surprised that it's affected in patients with acute pancreatitis, whether they had recurrence or no recurrence. And this is in the table on your right side. If they had recurrence, then they had more hospitalizations to the hospital. But what's kind of shocking is that both groups have vomiting, abdominal pain, and weight loss. So they're both in trouble. And then their quality of life by PedsQL score was definitely affected on the physical and emotional and other scores for functioning. And then genes predict progression, and this is definitely my last data. If you have more than one gene affected, you are at higher risk to progress to CP. And then the etiology, if it's genetic, it drives the progression to CP. And you can actually see the type of the timing to CP by type of gene does differ. So in conclusion, pancreatitis is an emerging problem in children, and a subset would progress to diabetes, recurrence, and chronic pancreatitis. The conditions affecting the pancreas in children are very unique, and they do require a pediatric expertise. And the acute pancreatitis in children, thankfully, to all the support that we have from around us, is really advancing. I thank all the patients, my team members, and the funding agencies, and all my collaborators. Thank you.
Thank you, Dr. Abul-Haja. So our next speaker probably doesn't need any introduction to this audience, but I will try. Dr. Roger Little from Duke University. He received his medical degree from Vanderbilt University and postdoctoral training at UCSF. And he's probably one of the few academicians who spent the longest time of the career at one institution, and that would be Duke University. And then he held numerous leadership positions there, including chief of GI. And his research includes, it really focuses on neurogenic processes that contributed to initiation, progression, and severity of acute pancreatitis. And recently he studies the pancreas sensing the pressure and role in several common causes of pancreatitis. You may also remember from him receiving the Lifetime Achievement Award and at the APA, and he also served as president. Okay, sorry. I know we're running a little late, sorry.
Thank you very much for that introduction. I was invited to talk about some work that we have done fairly recently in the lab on the role of phosphate in pancreatitis. And I will answer your question first, because what I get asked about most commonly is, why did you even think about this to begin with? And it was really based on a clinical observation when Ahmad Farouk was a GI fellow in the lab. And he had been working in the emergency room, and he said, you know, I've seen a couple of patients with acute pancreatitis who had hypophosphatemia. He says, I wonder if that could be involved in the pathogenesis of their pancreatitis. And I said, well, what is your idea? What's your hypothesis? And he says, I have no idea. But before I could tell him not to do the experiment, he embarked on a series of studies that I'm going to share with you now. We know that alcohol alone does not cause pancreatitis in animals. There is only one model that has been described, which is repeated high-dose binge alcohol, but it's very difficult to induce pancreatitis in animals by giving alcohol alone. And that's shown in this experiment in mice, in which we gave them alcohol to the point where they were moderately intoxicated over a period of 5 days, and they don't get pancreatitis. However, if we put animals on a low phosphate diet, they also don't get pancreatitis, and that's shown in red. And they actually have very normal looking pancreas. However, when we add alcohol to animals on a low phosphate diet, they develop pancreatitis almost immediately. And that's shown in this series of experiments. So the low phosphate diet induced low serum phosphate levels, as you might expect. They had equivalent levels of alcohol in their blood, which are levels that are achieved clinically in patients who are moderately intoxicated. And on a low phosphate diet, alcohol will indeed induce pancreatitis. Well, it would be natural to ask, can phosphate ameliorate that? If we give phosphate back, can we improve pancreatitis? And indeed, the answer to that is yes. Here in animals that were on a low phosphate diet and given alcohol and supplemented with phosphate, this could be given either orally or intraperitoneally. They will have an improvement in their pancreatitis. Interestingly, several of these animals actually died on the low phosphate diet when they were given alcohol, and their mortality was also corrected by phosphate supplementation. We were curious, of course, as to how this might occur, and we studied isolated pancreatic acinar cells to look at the potential toxic effects of phosphate and alcohol on acini. And what we observed was that acini from mice on a normal diet, so they were normal phosphatemic, had a response that was not induced by alcohol, but on acini from phosphate depleted animals, they had an increase in LDH release, trypsin activation that could be improved by phosphate supplementation. It had been known that alcohol feeding to animals, even though that did not induce pancreatitis, their mitochondria were not normal. This is a paper that was published in rats, in which rats on a high-fat diet given alcohol over a period of about 2 weeks had these electron micrographs taken of their pancreas. And as you can see on the left, in untreated animals, their mitochondria look relatively normal. However, the alcohol-fed animals had quite abnormal mitochondria with loss of Christie, shortening of their mitochondria, and rounding of the mitochondria. So we knew that there was some mitochondrial abnormality induced by alcohol, but they did not develop frank pancreatitis, so they were obviously compensated to some degree. When we looked at mitochondrial function in pancreatic acini from animals on a low phosphate diet, we observed that indeed their serum phosphate levels were low on the diet. They also had mitochondrial dysfunction, as you can see by the mitochondrial depolarization that occurred in the presence of alcohol, and then they were repleted with phosphate, and both their mitochondrial function was restored as were their ATP levels. Now, Ahmad has actually published a recent paper describing hypophosphatemia as a risk factor. It's a prognostic factor for alcohol-induced pancreatitis and it correlated with poorer outcomes. So the data that I've shown you thus far is on alcohol-induced pancreatitis. However, there are reports in the literature where hypophosphatemia has been associated with acute pancreatitis of pancreatitis of other etiologies, including either idiopathic pancreatitis or in this case, it was hypophosphatemia associated with in a patient with gallstone pancreatitis. So that prompted us to look at other causes of pancreatitis to determine if phosphate might predispose to increased severity in pancreatitis of either secretagogue stimulated pancreatitis, and in this model we looked at cerulean-induced pancreatitis, and what we observed was that low phosphate diet did indeed exacerbate cerulean-induced pancreatitis, and that phosphate supplementation ameliorated the cerulean-induced pancreatitis. So a low phosphate diet, hypophosphatemia, predisposed to increased severity of pancreatitis in this particular model. We all looked at a second model, and that was an ERCP-induced model of pancreatitis. And we studied mice on a low phosphate diet compared to a normal diet. And as seen in the cerulean-induced model, the animals on a low phosphate diet who underwent ERCP had worsening pancreatitis. And this could also be ameliorated by phosphate supplementation. So even in animals who were on a low phosphate diet or animals who were on a normal diet, so they were not hypophosphatemic, they also had an improvement in their pancreatitis with phosphate supplementation. Looking at this in vitro, we adopted what we thought would be an analogous model to ERCP-induced pancreatitis by taking advantage of the studies that we had done demonstrating that the pancreatic acinar cell is actually very sensitive to pressure. So we have demonstrated that pancreatic acini express the mechanically activated ion channel piezo-1, which is a mechanoreceptor, if you will. It is sensitive to pressure, and as an ion channel allows extracellular calcium to flow into the cell and can induce pancreatitis. And we think that's an explanation for several models of pressure-induced pancreatitis, including gallstone pancreatitis, trauma-induced pancreatitis, and so forth. Piezo can be activated by a chemical agonist. Here I'm showing you that particular agonist, YODA1. So YODA1 we used in vitro to activate piezo to reproduce what we think is an in vitro model, if you will, of pressure-induced pancreatitis. So taking advantage of that, we looked at the effects of phosphate supplementation on both CCK-induced pancreatitis in vitro, or at least what we think is a model of pancreatitis, and looked at the effects on CCK-induced pancreatitis and YODA1-induced pancreatitis and pancreatic acini. What we observe is that either with CCK or with YODA1, we see an elevation in intracellular calcium that's typical of that associated with secretagogue or pressure-induced pancreatitis by looking at the sustained elevations of calcium. In the bar graphs, we're looking at either peak calcium, which was not affected, but that sustained elevation, which is associated with pancreatitis, was improved by phosphate supplementation. Phosphate also improved CCK-induced mitochondrial depolarization and restored ATP levels in isolated acini. And it improved, phosphate also improved YOTA-1 induced acinar cell injury. Here we're looking at the depolarization of mitochondria by looking at TMRE fluorescence. And with depolarization and mitochondrial dysfunction, you see a decline in fluorescence. However, in the presence of phosphate in the bottom images there, you see that mitochondrial function is retained when phosphate is added to the media. So here is my summary slide. What we have observed is that low phosphate conditions predisposed to injury-induced pancreatitis. We think that this is related to changes in intracellular calcium, related to mitochondrial dysfunction and decreased ATP synthesis that results in enzyme activation and a cascade that we're familiar with in the pathogenesis of pancreatitis. When we restore phosphate, we maintain the ability of the cell to maintain the mitochondrial function, maintaining ATP levels, and calcium levels are not elevated into that pathophysiological range. So thank you very much for your attention, and I guess we'll take questions later. Okay, thank you.
Okay, our next speaker is Dr. Vijay Singh, professor at Mayo Clinic in Phoenix. He has interest in both clinical gastroenterology and research interests in pancreatic disorders that are quite broad. He's interested in both in the pathophysiology of acute and chronic pancreatitis. He's particularly interested in mechanisms regulating the function of pancreatic acinar cells, including vesicular trafficking, cytoskeletal regulation, and intracellular signal transduction. His interests over the last few years has been investigating how obesity-related pancreatic fat worsens local injury via unsaturated fatty acids. He also is doing some translational work and developing a technique known as transgastric local pancreatic hypothermia as a new rapid multimodal therapy for acute pancreatitis. And today he's going to talk to us about new drug therapies for pancreatitis. Vijay.
Thank you, Dr. Lowe, for the very kind introduction. And I'd like to thank the organizing committee for allowing us to share our ideas about new drug therapies in acute pancreatitis. That is my disclosure. It hasn't changed much over the last decade. While I'll be talking about a novel new therapy, which is in phase 1 trials for severity of acute pancreatitis, I believe it is important to highlight other important drugs that are relevant to pancreatitis, which have come up in the last 4 or 5 years. We can classify them into physiologic replacement, repurposing, and novel agents. And these are the publications. These are the drugs that have publications supporting that. As Dr. Little alluded to, phosphate has multiple roles in protecting from pancreatitis in multiple models. We have published on calcium supplementation, which essentially is Ringer's lactate, which has 3 milliequivalents of calcium in it, and how the calcium in Ringer lactate neutralizes fatty acids. The repurposing comes to tacrolimus. This is the intro trial, which is planned. Tacrolimus along with NSAIDs to reduce the severity, to reduce post-ERCP pancreatitis. Dabigatran is antithrombin and antitrypsin, and it has been shown in 2 seminal papers in JCI and JCI Insight to reduce the progression of acute to recurrent acute pancreatitis. Pirfenidone, which Marcus Lurch had highlighted earlier, and which Dr. Dudeja's team has worked on, basically increases IL-10 secretion and improves the resolution of pancreatitis. And then the novel drugs are CM4620, also called Axora, which is an ORAI1 inhibitor, has shown benefits in 3 different models, is currently in phase 2 trials. And then Spotin A41, recently published a class 3 PI3 kinase inhibitor, which is very similar to what we had found with Wortmannin about 20 years ago in reducing trypsinogen activation, abnormal vesicular trafficking, and thereby initiation of pancreatitis in cerulean. However, there are important differences in what we do in experimental models and what the human findings are. And these two papers highlight those important findings, and that is fat necrosis. So fat necrosis has been shown both by surgeons as well as pathologists in human autopsies. For example, the paper on the right is a paper by Gunter Kloppel in Germany, a pathologist who describes 367 autopsies he did in humans with pancreatitis. And he goes on to say that fat necrosis was present in all cases, irrespective of etiology, duration, or severity. On the right is the paper by a surgeon, a Finnish surgeon, and Nordback over here describes 79 cases on when he operated early. These papers were written when there was early surgery done in the first 4 days of pancreatitis. And he clearly says that the most vulnerable areas seem to be the peripancreatic adipose tissue, from where the necrosis spread through the septa towards the pancreatic parenchyma. And he found that 100% of cases had pancreatic fat necrosis present. So pancreatic fat necrosis is therefore a universal phenomenon in pancreatitis, though we often ignore it in our models. Now, what is pancreatic fat necrosis? The slide summarizes this to a reductionist model. So on the left is the classical thing, what cerulean causes in pancreatic acini. The green is GFP actin. In the center, you can see the apical lumen of the acinus, from where cells normally secrete the zymogen granules. But over here, you see with hyperstimulation, the greens and the red zymogen granules are leaked basolaterally into the interstitium. And on the right is, once lipase is leaked out, on the right, you see adipocytes that are stained green with lipid droplet stain. And in a second, you will see exposure to lipase. That red, which you saw coming up, was M-cherry pancreatic lipase. And when we add it to these cells, you see it entering cells, and that is fat necrosis in action. You see those adipocytes bursting, the lipid droplets getting hydrolyzed, and fat necrosis taking place in these cells. So this is a reductionist model of what the pathologists and surgeons have described. So based on this, if we look at what we have seen in the reductionist model, and then we say, okay, what do we see radiologically in CT scans? This is a common finding we see in our pancreatitis patients. In the bottom image, if you can see the normal patient, the same patient before he had AP, and on the right side is after he had developed Waldorf pancreatic necrosis, which essentially is a big mass, and it contains dead pancreas and dead fat, or fat necrosis. And when we went on to measure serum fatty acids in patients with various grades of pancreatitis, mild to moderate and severe pancreatitis, we find unsaturated fatty acids to be elevated in the patients with severe pancreatitis. And overall, if you look at total NEFAs, they are somewhere in the 1 to 2 millimolar range. And that is an important number to keep in mind when we go further to our animal models. So pathophysiologically, if we try to understand what we have seen so far, is that the unsaturated fatty acid elevations that occur come from fat necrosis, and the schematic in the center describes a sequence of fat necrosis. That basically there's a pancreas, there's fat around the pancreas has acini in pink, and they'll leak out their enzymes basolaterally. They go into the adipocytes, which get necrosed, and the E-shaped structures in the cluster of adipocytes on the left side, which is triglyceride, gets hydrolyzed to fatty acid, which are those red squiggly lines. Those fatty acids then enter the circulation and cause multisystem organ failure by injuring the lungs, the endothelium, and causing also cytokine hyperinflammatory response. And we have shown in 4 different papers that if we take a pancreatitis model, modify it with fat, it gets the characteristics of human severe pancreatitis with multisystem organ failure. But if we inhibit that with a lipase inhibitor, it goes back to mild pancreatitis and severity is prevented. The lipase inhibitor, however, that has been used so far is orlistat. And orlistat is the only FDA-approved agent which has limitations that it is low in potency. Whenever we had to give orlistat, we had to give it as multiple doses twice a day for up to 3 days, which is not practical in a human. And it required a vehicle that was not clinically relevant. So we said, what can we do to go above and beyond orlistat, so make this a one-time therapy that can be used? And there came RABI-767. RABI-767 is a lipase inhibitor which is 20 to 200 times more potent than orlistat. In this panel, you can see the IC50s. In green is RABI-767, and in black is orlistat. On the left is the enzyme human PLRP2, as it's very, very potent against that. And in the middle is human pancreatic triglyceride lipase. On the right side is the panel showing its aquastability without any vehicle on the bench overnight. And we can see that it retains its potency, whereas orlistat loses potency despite a solvent. So we went on to compare orlistat and 767 in two mechanistically distinct animal models therapeutically, that is, giving the drugs after establishing pancreatitis, after it had been well established. The first was obese mice with cerulean pancreatitis, and the drugs were given about 6 to 8 hours after pancreatitis had already been initiated. And you can see the serum lipase levels over there. They were 5 to 10-fold above normal when these drugs were given. This picture, this movie describes well what we saw. On the right is the mouse that got 1 dose of 767 2 days into pancreatitis. And you can see that he's active, whereas the one in the center was the one who got a single dose of orlistat. And you can flip him around and the mouse cannot come back to normal. So they, over time, progress, become moribund, and we have to euthanize them. So this was a universal phenomena we saw in mice given RABI-767. We went on to measure parameters of inflammation, SIRS, and organ failure. Over here on the left side, you can see a mouse given orlistat, a single dose, still has fat necrosis, the white cheesy material you can see there. Whereas the mouse on the right, given 767, had much less fat necrosis. 767 also prevented hypocalcemia, which is a part of Ranson's criteria. In severe pancreatitis, it prevented SIRS as seen by normalizing rectal temperatures, and also prevented leukopenia, which is a part of severe SIRS. Again, over here, we can see in green that 767 prevented organ failure. BUN elevations that occurred in severe pancreatitis were prevented, as was the drop in carotid pulse distension. Pulse distension is a marker for shock, which we use in mice by putting a collar and measuring how much the carotid artery distends. Normally, this is around 400 microns, and below 200 is shock. And overall, 767 improved survival when given therapeutically. We also saw a dramatic reduction in the cytokine storm. IL-6 went up by about 100 to 1,000-fold in severe pancreatitis, which was normalized by 767. So was MCP1 and TNF-alpha, but not by orlistat single dose. We went on to a second model in which we tested this even in a more severe model where we gave the drugs 40 hours into pancreatitis. And that's on the left graph, you can see where we gave the drug. This was 40 hours, and soon after that, we saw survival going down. This was after 2 injections of IL-12/18. And you can see that among 767 mice, only 1 out of 6 was lost, whereas all were lost in the untreated group. The drug was given at a time when the lipase was already 20-fold the upper limit of normal, as you can see on the right side, that 767 was given when lipase was around 2,000. And this is important over here, that the fatty acids were already elevated by the time we gave 767. And these are very much in the range of what we see in human severe pancreatitis. Even though the fatty acids were in the 1.5 millimolar range, by the time pancreatitis, we necropsied them and the mice survived, except for the one mouse we lost, all of them had normal serum fatty acids. Similarly, organ failure was prevented in the 767 group by normalization of the blood urea nitrogen in the green dots, normalization of rectal temperature, which is severe SIRS, and normalization of pulse distension. We also saw prevention of the cytokine response, IL-6, MCP1, and TNF-alpha, all were normalized except for the 1 mouse, which we lost. So overall, what we can see is that that the progression of severe pancreatitis, which occurs because of fat necrosis, which the pathologists have shown, which surgeons have shown in humans to happen, can be prevented by RABI 767 given therapeutically into the peritoneal cavity of mice. The strengths of 767 are 20 to 200, that its potency is 20 to 200 times higher than orlistat. It requires only a single dose, and it is in a clinically relevant vehicle that can be used in humans. The current status of 767 is that it is in phase 1 clinical trials, and from what I hear, they're going well. Phase 2 trials are planned for next year. And if you have any questions, I will be glad to answer them. I would like to thank my lab and collaborators for the efforts and contribution to this work. Thank you.
Thank you, Dr. Singh. And our last speaker of the session is Dr. Venkat Akshintala from Johns Hopkins University School of Medicine. He's an assistant professor of medicine at Johns Hopkins and also an adjunct assistant professor of the Asian Institute of Gastroenterology in India. His research is on advanced endoscopy and medical pancreatology. He's also the program director for the fellowship program and directs advanced endoscopy fellowship program at Johns Hopkins. And he will talk to us about nutrition, microbiota, causal role versus effect of pancreatitis.
Thank you, Dr. Ruch, for this kind introduction. I thank the moderators and APA for giving me this opportunity to speak on this interesting and important topic, nutrition, microbiota, causal role versus effect of acute pancreatitis. These are my disclosures. And this is the outline of my presentation. Given the breadth of this topic and all these entities involved, which is nutrition, microbiome, and acute pancreatitis, I will try to break it down into the causal role and effect of nutrition on acute pancreatitis, then on microbiome, causal role and effect on acute pancreatitis, then on nutrition for microbiome modulation in the management of acute pancreatitis. And first, talking about the nutrition and acute pancreatitis. Historically, the notion was on keeping the pancreas rest by making the patient NPO, but there was no strong evidence to it. And multiple randomized controlled trials showed that patients tolerate early enteral nutrition pretty well. This is a meta-analysis of 5 randomized controlled trials with 569 patients that showed that early enteral nutrition reduces the length of stay for patients with acute pancreatitis, and guidelines have been supporting early enteral nutrition, which is in the first 24 hours. And like Dr. Singh has previously mentioned, this is even more important among patients who are obese and who have a lot more fat maybe around the pancreas. And in this randomized controlled trial that specifically looked at obese patients, early enteral nutrition reduced the length of stay and also necrotic related complications. So again, supporting the importance of early enteral nutrition. And among patients with acute pancreatitis, especially severe, need adequate nutrition and support due to the loss of nutrients, electrolytes, and dysregulation of the acid-base balance in an inflammatory state. Acute pancreatitis is characterized by protein catabolism, leading to a negative nitrogen balance and emphasizing the importance of nutrition. And when patients are kept NPO, there is a risk of gut barrier dysfunction that increases risk of transmigration of the gut microbiota, which I will be discussing more in the next section. There have been many randomized control trials looking at enteral versus total parenteral nutrition, 12 randomized control trials, and the meta-analysis showed that patients on TPN have higher rate of hospitalization, higher length of hospitalization, organ failure, and pancreatic infection. So we have seen all these clinical trials and evidence on the importance of early enteral nutrition. Let us now see how good we have been in following early enteral nutrition. This is a study by Apprentice 1 Consortium that looked at patients from 22 centers with acute pancreatitis. This is one of the largest such studies, and they had around 1,200 patients in whom early oral nutrition was attempted. In this specific subcohort of 1,229 patients, most of the patients had mild to moderate pancreatitis, 94.9%. And even in this subset, only 23.6% had early enteral nutrition, which is diet initiation in the first 1 to 2 days, which is surprising and suboptimal. And these are all academic centers, and this is a recent study. And the reasons are unclear. Unsure why we have been non-compliant with the guideline recommendations or what other factors have been involved. As you can see in the table here, whatever the day of initiation it has been, the tolerance to early nutrition has been pretty similar. There was no statistical significance, whether diet was initiated on day 1 to 2 or day 3 or day 4 and so on. So we are continuing with Apprentice 2 consortium. So we are conducting a multi-center pragmatic step-wise cluster randomized control trial to understand early enteral nutrition better and understand the challenges involved with early enteral nutrition. And we currently have our colleagues from the Chinese centers currently setting up this study. And the next question on composition of enteral nutrition. The data on ideal composition of diet in acute pancreatitis are limited, and successive refeeding has been reported with a wide variety of oral diets, including normal fat, low fats, soft diets of all consistencies. In one study, soft low-fat diet or with low residue diet was shown to provide more calories versus clear liquid diet in acute pancreatitis patients without increasing pain. And in another study, soft diet led to decrease in the length of hospitalization, again, showing that anything can be used as early enteral nutrition possibly. Now moving on to the next section on microbiome and acute pancreatitis, the cause and effect relationship. And gut microbiome is a key component of intestinal ecosystem, which protects the gut barrier. Several preclinical and human studies have reported dysbiosis of gut microbiome in acute pancreatitis. And gut microbial dysbiosis was observed in the early stages of acute pancreatitis. And there is questionable causal relationship here rather than just an association. And in several preclinical studies, mice pre-treated with broad-spectrum antibiotics and germ-free mice showed attenuation of pancreatic injury, mortality with severe acute pancreatitis. Again, showing a signal that this may be more than mere association and there may be some causal relationship here. And in this one study that looked at patients with severe acute pancreatitis, and they noted that acute pancreatitis associated microbiome replaced the host-specific microbiome. Severe acute pancreatitis patients had decreased bifidobacterium and increased Enterobacteriaceae and Enterococcus. And they also noted that inflammatory markers like serum IL-6 were positively correlated with Enterobacteriaceae and Enterococcus. The rates of multisystem organ failure and infectious complications in patients with severe acute pancreatitis were higher among patients who had altered gut microbiome, again, emphasizing the importance of gut microbiome on the severity of pancreatitis also. And there have been very few studies that looked at human gut microbiome or dysbiosis in acute pancreatitis. And this study was previously presented by Dr. Abu Al-Hajjah's group, Dr. DK. And in this predominantly pediatric group, they showed that dysbiosis among patients with acute pancreatitis when compared to healthy cohorts. And this is another study fresh out of press. And this is a study by Dr. Yaziki, and who showed that there is dysbiosis in patients with acute pancreatitis. And very interestingly, the dysbiosis was more pronounced among patients with acute pancreatitis and diabetes, which was statistically significant. And interestingly, this is another publication from Dr. Talukdar, who showed the microbiome to be very different among patients with pancreatogenic diabetes when compared to type 1, type 2 diabetes. Putting everything together, maybe among patients with diabetes and pancreatitis, there may be a compounding effect on leading to dysbiosis, which needs to be further explored. And let us review the mechanisms of gut microbiome dysbiosis in acute pancreatitis. It may be from intestinal dysmotility because GI dysmotility exists in acute pancreatitis patients from dysfunction of interstitial cells of Cajal and myenteric neurons. And the increasing duration of migrating motor complex is suspected to lead to overgrowth of gram-negative and anaerobic microflora. And there is also the phenomenon of ischemic reperfusion injury. The release of pro-inflammatory cytokines like TNF-alpha lead to mucosal injury and impacting the intestinal microcirculation. And the third is possibly from oxidative stress, and which impacts the gut barrier and overgrowth of oxygen-tolerant bacteria like proteobacteria and actinobacteria. And now let's review the impact of gut microbiome dysbiosis on acute pancreatitis pathogenesis. Gut dysbiosis leads to necrosis of gut epithelial cells, thinning of mucus layer, and destruction of tight junctions. Intestinal microbiota pass through this impaired gut barrier, but that leads to bacterial translocation, aggravating systemic inflammation and causing secondary infections. Gut origin microflora were detected in peripheral blood, in mesenteric lymph nodes, and also in distant organs like liver, spleen, and lung. And it is not just pancreatitis or pancreatic complications that we see from dysbiosis. This one study showed that dysbiosis leads to an acute lung injury. In this preclinical study, mesenteric lymph from rats with severe acute pancreatitis were injected into healthy rats that led to acute lung injury. However, when mesenteric lymphatic ligation was performed, there was reduced acute lung injury, again, confirming a causal relationship to multisystem organ failure from gut microbiome dysbiosis. Now going on to the final topic on nutrition and microbiota-based interventions in acute pancreatitis. So I would try to focus on things that we can do possibly in clinical care very soon, or try to understand this better. The goal here is to reset the entire gut microbiome. And the different interventions that have been tried are, the first are short-chain fatty acids. Short-chain fatty acids are organic fatty acids produced by symbiotic intestinal bacteria through anaerobic fermentation of dietary fiber. These mainly include acetic acid, propionic acid, and butyric acid. And they have an important role in providing energy to the intestinal epithelial cells and maintaining the intestinal microecological homeostasis. And in these preclinical studies, short-chain fatty acid substrates were shown to be possibly having a therapeutic benefit among animals with severe acute pancreatitis. So they have used butyrate and showed a positive effect in the setting of severe acute pancreatitis. It is not just butyrate. There are other substrates, right, like fiber-rich diet, starch, okra protein, and low methoxyl lemon pectin that were all shown to increase short-chain fatty acids butyrate, providing improvement of the gut barrier. So all of these have possible therapeutic benefit, and these were extensively used in the IBD setting, and there are possibly things we can learn from the IBD world. The next is fecal microbiota transplant. Fecal microbiota transplant involves the transfer of feces from healthy donors into acute pancreatitis patients to restore the microbiota. And this has also been extensively used in the setting of IBD, recurrent C. diff infection, and hepatic encephalopathy. However, in experimental studies, there was no positive effect on fecal microbiota transplant, and they actually saw more significant damage and a more significant pancreatitis when fecal microbiota transplant was performed. The next, I will be going over probiotics briefly. Probiotics are known to enhance the gut barrier by inducing the production of mucus, enhancing the tight junctions, and attenuating apoptosis of epithelial cells. Probiotics are able to affect gut motility also, and increase the production of short-chain fatty acids and interacting with the enteric nervous system. And there have been several randomized control trials that looked at probiotics, and smaller trials actually showed a benefit with the use of probiotics, especially with the length of stay, though they did not show any mortality benefit or with infectious complications associated with pancreatitis. And this is one landmark clinical trial, randomized control trial, the Pancreatitis trial, that looked at probiotics in the setting of severe acute pancreatitis. They randomized 298 patients with predicted severe acute pancreatitis within the first 72 hours into a moderate dose of probiotics or to placebo. They actually saw that the probiotic group had higher rate of infectious complications and also higher mortality, 16% versus 6%. The reason for this was not very clear, but the hypothesis was that in the setting of severe acute pancreatitis, there is already mucosal and hypoperfusion injury. And on top of it, when the patients were given enteral nutrition and this high dose of probiotics, that might have increased the oxygen demand and more perfusion injury, because the patients in the probiotic group had higher bowel ischemia that was noted on necropsies. And briefly reviewing in the role of antibiotics, the antibiotics have been extensively studied in the setting of acute pancreatitis for prophylaxis against infectious complications, and they showed no benefit, and guidelines do not recommend the use of antibiotics. So maybe a shotgun approach against this microbiome might not be the right way. In conclusion, early enteral nutrition of any type is well tolerated and reduces the length of stay. Enteral nutrition has lower risk of infection mortality complications compared to total parenteral nutrition, likely due to the impact on gut mucosal barrier. Acute pancreatitis leads to gut microbiome dysbiosis, as we saw, and whether gut microbiome dysbiosis is a mere association or has a causal relationship is yet to be determined. There are therapies that focused on gut microbiome, especially the short-chain fatty acids that hold promise, as was extensively studied by the IBD world. While not the ultimate weapon, nutrition and microbiome modulation has an important role in the management of acute pancreatitis, along with other therapies. Thank you.
I'll ask the speakers to come up, and anyone who has questions, please come up to the microphone. It's on.
We have about 14 minutes for questions.
So Al?
Start? Okay,
ahead.
great. Thank you, Mark. Great session. I had a question for Roger. Fascinating work about phosphate, and you went through several studies, including the one clinically that was published in Pancreas. I guess my question is, how pervasive of a problem do you think it is, and to what extent? Because I mean, we don't check phosphate, right, routinely. And secondly, you can get phosphate depletion with phosphate excretion, losses, DKA, ICU care. And then interestingly, we think about like hyperparathyroidism and its association with pancreatitis. And we think about hypercalcemia as a potential reason, but it also causes phosphate depletion. So how pervasive is the problem, and to what extent do you think it would be contributing in other situations that are at risk for causing pancreatitis?
Yeah, that's a great question. And the short answer is it's more common than we recognize. But you're right. We typically don't measure phosphate in patients who are admitted to the hospital. It's not part of our routine chemistry panel. So we really don't know. When we did, a retrospective study at our place, and it was about a third of patients may have hypophosphatemia during the course of their hospitalization. But it's hard to know what the course of hypophosphatemia really is. So unless it's measured, when they present, it's hard to tell whether factors that may be introduced during their hospitalization could be contributing. So we were looking at the first phosphate level measured, for instance, but you're right. Alcoholism can induce hypophosphatemia. If they're admitted to the hospital and you refeed them, refeeding syndrome can induce hypophosphatemia. There are a lot of factors that could be at play. So what we need is, a prospective study to measure phosphate in every patient who's admitted to the hospital and see what that pattern of phosphate is through their hospitalization. And then we could get an idea as to whether intervening would be appropriate. Yeah.
Dr. Gosta.
Also, question for Dr. Liddle. So excellent study, and I like what you measured for mitochondria. So I wonder if you plan to measure with seahorse oxidative phosphorylation, because phosphate really is necessary for both to block PTP and for oxidative phosphorylation. And it can be done just, for example, you can measure the effect of the inhibitor of phosphate carrier, which transport phosphate from cytosol to mitochondria, and see if it is similar effect with the depletion of phosphate, because really it is critical factor for two things: oxidative phosphorylation and permeability transition. And we know even from our publications that alcohol sensitizes pancreatic mitochondria to these things, to both defects.
Thank you. Yeah, that's an excellent suggestion. We'll get together, okay? Thank you.
Thank you, Robert Sutton from Liverpool. I was very encouraged by your work, Dr. Singh, with the RABI 767. And I think it's great that compounds that have really powerful preclinical evidence are being developed and going through phase 1, because we need a pipeline of trials for acute pancreatitis, which we don't have, and chronic as well. Really encouraged by those very powerful results. Thank you. I was actually going to raise the same point that Anna did about the seahorse, because that would enable you to determine whether it's actually affecting the F0, F1 ATP synthase function. And also I wanted to comment about the clinical relevance. And obviously taking phosphate measurements in patients who have had alcohol abuse or individuals who are abusing alcohol would be very valuable on a longitudinal basis, but also possibly a word of caution in that there are both preclinical and clinical data that indicate that severity of acute pancreatitis is related to phosphate concentrations in the serum early in the disease, positively, a positive correlation. So more severe disease with higher phosphate. So if one wanted to intervene early with some form of phosphate supplementation, that might be a little bit tricky.
Yeah, I think you're exactly right. And, it's actually been reported that some patients with severe pancreatitis have hyperphosphatemia at some course. We've actually had the opportunity to follow some patients with pancreatitis, and there is a dynamic process in which phosphate levels change during the course of their pancreatitis. I was encouraged by the studies in which we gave phosphate to animals that were on a normal diet, so they were normal phosphatemic, and phosphate still had a protective effect. So hopefully there's a window there that you could intervene.
Hi, my question is for Dr. Liddle. I just follow the Sohail comment about the calcium levels. I know that it's always a balance between the phosphate level and the calcium level in bloodstream. I just wonder if you study the level of calcium in those animals that were provide high levels of phosphate, and if there is a correlation with the low level of calcium in the blood with a low level of calcium inside the cells, that maybe can in this way prevent an acute or relieve the acute pancreatitis, not only because of the mechanical effect that you mentioned, but also it's just the low level of calcium in the blood.
Yeah, that's a great point. In those studies, we did not measure serum calcium levels, but it's a great point. Yeah, thanks.
If there are no questions, I can ask a question to Dr. Abu Al-Haja. So very nice talk and very nice session, by the way. You presented, of course, the NASPGHAN guidelines about the fluids. And we give about 10 to 20 cc per kilogram of bolus, followed by 1.5 time maintenance for 24 to 48 hours, and we reevaluate. Do you see patients perhaps, with fluid overload, and do you change your management based on perhaps their age and their BMI, especially with, the adults and the New England Journal of Medicine waterfall trial, where they have seen more patients with the adult age group with the fluid overload?
Yeah. Thank you, Aliyah. It's a very important remark. So thank you for asking that, especially with the waterfall study being kind of newly published. It does beg the question, is the aggressive fluid management really should be that aggressive, or what is really the balance or the tight line? So far, we do not have studies in pediatrics, as you know, to resemble what they showed in the waterfall study, where could we randomize the patients to get normal resuscitation versus the high fluid resuscitation? What I would say, though, our aggressive fluid resuscitation per the guidelines calls for the first 24 hours, and the waterfall was more for 3 days initially. But definitely, we also want to do a goal-directed management. So if there is a significant amount of third spacing and SIRS and possible even pulmonary edema or pleural effusions, then that is the patient who's not, if they're not diuresing, we should not be just pumping fluids in them, but we still don't have that data.
Hello.
Thank you.
Yeah, I have one question. My Sandeep Swami from Deep University. So I have one question from Dr. Vijay Singh, that always I was on my research with Dr. Liddle, always I give importance to carboxylipase, the phospholipase enzyme in my I always give, I don't know why, but the Rabi 767, the enzyme you are using, so how it is block all lipase or one specific lipase. So the question is that different type of lipase is there, and we don't know which type of lipase actually really playing big role in the acute pancreatitis and chronic pancreatitis. So do you think this lipase will be still work in the chronic pancreatitis or only for acute pancreatitis?
So from what I'm understanding, your question relates to whether 767 in what lipases it inhibits
Yes.
and what kind of pancreatitis these
Pancreatitis,
lipases are
right,
relevant
can
to?
be work for both acute and chronic.
Okay, so we have tested 767 for all three pancreatic lipases. I showed two of them, PLRP2 and pancreatic triglyceride lipase, but it's also much more potent also for carboxyl ester lipase. So that's all three pancreatic lipases are inhibited. We have not looked at other lipases that are relevant, but the reason we have focused on pancreatic lipases is we have previously shown that pancreatic triglyceride lipase, which is about 80% of pancreatic lipase activity, is the dominant lipase, which causes fat necrosis and the progression of disease. As per, was the second part of your question relevant to progression to chronic? Okay. Yes, so I don't want to make claims about that now, right now, but let's see what happens in acute. If we get a benefit in acute, the usual progression that we hypothesize and believe in is that acute becomes recurrent acute and recurrent acute becomes chronic. So if we do see a benefit in acute, maybe less fat necrosis, less fibrosis, therefore, perhaps we can put a damper on these phenomena too, but I would not like to overstate that right now.
Thank you.
Okay. I'll ask one last question of Dr. Eshantala. So we've seen a lot of several studies now that are showing that there are changes in the microbiome in patients who have acute pancreatitis as well as chronic pancreatitis. Question is how quickly, what do you see changes in the microbiome over time? Does it make sense that they occurred within that time frame?
Thanks for the question. I think mechanistically it makes sense because acute pancreatitis, the immediate phenomenon, we see damage to the gut mucosal barrier right away, and we see transmigration of the gut flora pretty early. So these changes might be occurring early on. And that was the reason, and especially in some other situations where people were trying to intervene on the gut microbiome, they were trying to start the interventions pretty early. So if we want to intervene on something similar in acute pancreatitis, we may want to consider an intervention early on as well.
I have a comment to make on that too, because that's really a very relevant question that the infectious disease collaborators have asked us when they ran the specimens. And for that reason, our design included within the same subject that they come back to clinic and drop a sample 3 months later at the 3 months mark and 1 year. Of course, people don't like to provide poop samples for whatever reason, but this is where maybe some of these questions could be about even within the same subject, does it change after recovery from the pancreatitis? So hopefully stay tuned for some more work.
All right, any other questions? All right, I think that concludes our session. Thank you, our speakers. That has been a wonderful session, and thank you, the audience, for participating. Finish 1 minute ahead of